I want to thank everybody for coming, and I'm going to introduce our speaker today. I'm going to start off this conversation by saying, for every story he tells about me, I'm going to tell 3 about him, okay? So, we're very happy to have one of my best friends to come speak to us today, Dr. David Adair. Actually started his academic career here. David actually did his residency at the University of Florida, Jacksonville. Then he went to Bowman Gray and did a fellowship in maternal and fetal medicine. When David finished his fellowship, he had 65 peer-reviewed publications. And he's continued to publish a lot over the years. He's also very much an entrepreneur, and he's has multiple patents. He's going to talk to us about a drug today that we actually had a patient on labor and delivery on a study. David's currently Vice Chairman and Professor of the Department of Obstetrics and Gynecology, Section of Maternal and Fetal Medicine at the University of Tennessee in Chattanooga. David, come talk. Glad to have you.
Well, thank you. There's 2 chairs that are open right now that I used to think when I was in training I really would want. The University of Florida in Jacksonville and Wake Forest. When I came here, I fell in love with Shreveport. And so when David decides to retire, maybe I'll come be the chair. He wouldn't hire me.
I'll say it if they do.
Let me give you the conflict statements. I do have patent rights for Digibind, which is an immune fragment antibody for preeclampsia. I'm a significant equity owner of a thing called Velo Bio, which is the company that is sponsoring this trial. Okay? So, full disclosure. I have other conflicts. When UT plays LSU, who do I root for? Okay, so I've grown akin to like the purple and yellow. Okay, and which city do I love more, Chattanooga or Shreveport? They're very similar, and I've made my eating rounds. I did Herbie K's yesterday for lunch. We did Superior last night for dinner, and we hit Strawn's this morning for breakfast. And we had coconut, chocolate, and strawberry pie for dessert. Okay, so you guys have got some great food here. The talk is sponsored by Superior Grill. There'll be margaritas afterwards, okay? And it may be better if we do them now. You'll probably learn more, right? Okay, so our objectives. I'd like to talk to you about EDLFs, and that S is not a misprint, okay? It stands for Endogenous Digitalis-like factors. These are compounds that we believe are made in the placenta, the fetal adrenal gland, and quite possibly in the maternal adrenal gland that stoichiometrically look like digoxin. Okay? And there's probably multiple of these. So it's not one factor, that's why there's plural. We're going to look at some of the pathophysiology of EDLF in obstetrics and neonatology, and review the evidence of a proposed therapy to reverse those effects. Okay? EDLF, since it's like digoxin, inhibits sodium potassium ATPase pumps. So it causes pathophysiologic expression. If you could reverse that, then you would restore things back to a kind of normal state of affairs. So let's talk about preeclampsia first. This is a paper that came out last year, short-term cost of preeclampsia to the U.S. healthcare system. Okay? A bunch of smart people who are masters of public health, and then you got 2 MFMs here. Okay? The latter one, Baha Sabai, the godfather of preeclampsia. Okay? This is in the Gray Journal. They estimated, looking at sophisticated ICD-10 and 9 coding, etc., based on California, and extrapolated that out through the whole 50 states, and it came up basically that preeclampsia costs $2.18 billion to the healthcare system. Okay? Of that, roughly 1.03 was mom. The bigger thing is 1.15 billion for neonatal. I have a little problem with these numbers. I think those numbers are grossly underestimating the significance of this problem. I think it's probably higher than that because I know what the neonatal folks charge. If you look at national trends, okay, the total expenditure, according to the March of Dimes, is $26 billion a year for all obstetrical care, childbirth. Okay? So that's the obstetrical and the neonatal care. The New York Times estimates it at $50 billion annually. It's a more recent number. So if you play around with Baha's numbers, about 4.5 to maybe 8.5% of all healthcare dollars that's allocated for women in childbirth is being spent and consumed by preeclampsia and its complications. So it's an expensive disorder. Most of the neonatal cost really is about 29 weeks and earlier. So on our study, we're trying to concentrate on the early onset severe preeclampsia because those are the ones that's going to cost the most money. 22 to 23 weeks, there's no cost because those are non-viable infants. As you start getting into viability and the limits of viability, you can see that the cost can be significant, $150,000 plus. Now, preeclampsia results in premature birth. But a preeclamptic premature baby is not the same as an idiopathic preterm labor baby. Okay, so preterm labor, whatever you want to look at. When you look at complications in a non-preeclamptic preterm versus preeclamptic, you can see chronic lung disease, IVH, NEC, RDS, and sepsis are significantly elevated as compared to the gestational age, weight-matched, non-preeclamptic baby. So suggesting that they may have an underlying pathophysiology that may be different than what we see in normal idiopathic preterm birth. Now, moms have a higher incidence of thrombocytopenia, DIC, acute renal failure, and hemorrhage. Okay? And you see that on labor and delivery. That's nothing new to you, right? You cut the cord, you forget about the baby. So what we're really concentrating on is the baby. Mom, if we deliver them, generally, what do we say? 24 hours, you're going to be fine, etc. That may not always be true. There's some long-term problems we've got to worry about in their health care, but in general, that's a fairly accurate statement. If we're going to make a difference, this is where we got to make a difference, and that's on neonatal outcomes and impact. Okay, so we got some good folks here. Residents, students, right? Okay. Shaking your head, both. Okay, is that right? Yeah, both? Okay. Residents, okay, good. All right, so we're flash back to, your molecular biology. It's going to be real easy, okay? We're going to concentrate really on cellular membranes. Because sodium potassium ATPase is a transmembranal pump made up of an alpha unit and a beta unit. There's 3 isotypes of alpha, 1, 2, and 3. We're not real smart, so we just number them. Beta, there's 2, 1 and 2. And that combination is preserved from the lowest life forms, amoebas, through the plant kingdom and the animal kingdom. So it has to be a very important thing theologically for it to be preserved in that many species and then in higher orders. Okay? So it's very important. What does it do? It determines electrochemical gradients and maintains life. So if you look at the way it works, it binds 3 sodium intracellular and exchanges that for 2 potassiums extracellular. In the process, phosphorylation of ATP, which is energy dependent, goes to ADP, and you also get a byproduct of increase in the sequestration of calcium intracellularly. So it maintains excitability, okay? Membrane potential. Membranes, if you look at preeclamptic patients, they're membranes, that fluidity. Okay? Remember the membranes, because they're bilayer, they can float on each other, they can spin, they can flip, all that stuff. Preeclamptic membranes in the cell become rigid. They're like fullbacks. Okay? LSU, when you had what's the guy that just got fired? He loves fullbacks. They're big. They go through the line. They take hits. Cells get hit, then undergo apoptosis and lysis of their content, resulting in thrombocytopenia, hemolysis, etc. So that's a unique thing in preeclampsia is the fluidity. That's maintained by this pump. And that's really what we're going to be talking about because these factors inhibit this pump. The proposed therapeutic binds to the free form as well as those that are bound to pumps and pulls them off because they have a higher affinity. And it restores them back to euphysiologic state. So some background. Radioimmunoassays, RIAs, were developed in the 60s. This was a major scientific advancement because you could measure things. It was used to measure, in this case, digoxin. So it was a clinical lab. You're on digoxin, it has a very narrow therapeutic window. Get too much, you die. Not enough, you're not treated. So RIAs were used to do the therapy. Okay? They started noticing in neonates who were on digoxin that there was exceedingly high levels, even though they were on small doses. So suggesting there's some kind of interference. Then ultimately, somebody did a digoxin level on a baby who was not on digoxin and found that they were positive. Then they started looking at amniotic fluid, cord blood, placenta, the mom. They found that these things were elevated, but they're not on digoxin. Thus, the coinage of the name Endogenous Digitalis-like factors, EDLF. So they considered this from a stoichiometric standpoint to be a cross-reactant. I'm not real smart. I'm from West Virginia. Okay, so English is a second language for me. A softball glove, okay, that's an antibody. A softball glove can catch a ping pong ball, a tennis ball, a baseball, a softball, whatever. It cross-reacts. So using that, a lot of literature got developed because they were using something that was bad as a good way of understanding research. Now, from a commercial standpoint, that's not very good. Okay? So, because that cross-reactivity gives you false results. But people continue to do this, and they looked at renal disease, hypertension, cardiac disease, OB, neonatal, and even oncology. Okay? MD Anderson's manipulating sodium pumps now so that they cover them up. If it's a normal pump, they can go through a digoxin, like putting a helmet on. Okay? It protects it. The cancer cells have abnormal expression of isotypes of the sodium pump, so they can go through with lower doses of chemotherapeutics and selectively target the cancer cell and preserve the normal cell. So there's a lot of manipulation around this. And so there's therapeutic opportunities in a lot of these fields. For us, we're going to talk about preeclampsia and how we could use a polyclonal fragmented antibody that's raised in sheep to digoxin and use it as a therapy. So most of these things were done with these commercial available RIAs. The most prominent one is called New England Nuclear. And basically what it does, it binds to the free expression, okay, so it's not bound. And if you get it in the wrong time frame, you could get a false negative. If you had a high expression, then you could get a false positive. Now, using this cross-reactivity, a bunch of papers got published in the early 80s around this and how that this was something that was causing preeclampsia, etc. 1987, notice the name again, Baha Sabat, published 3 papers that basically said it does not work and there's nothing to this, okay? Because when he was using the RIA, that's hard for me, I'm Irish too, so we have the IRAs over there. Of course, the troubles are over now. But he said, this is dead. So he killed it. What he didn't recognize or realize was that New England Nuclear had changed their RIA to become more specific. So it was like a softball glove that could only catch a softball. No longer could it cross-react with a baseball, tennis ball, ping pong ball. Very selective. So that's great commercially for when you're measuring digoxin because you really want to know exactly what that level is. Any art fans? Okay. So can you name a famous artist that had his pumps, I'll give you that, he's a male. His pumps were manipulated, which probably resulted in some of his most brilliant works. Any ideas? Well, you can smoke dope and go to his museum in Amsterdam, the Van Gogh, okay? His brilliant use of light, okay, were probably induced from a plant called foxglove. And for you ladies, if you want to kill your guy, okay, you get some foxglove. It's odorless, it's tasteless, it's colorless. You put it in the wine. Queens bumped off the kings all the time with this. That's why the kings had to have wine tasters. And it inhibits them, and they go into death. And it's a digoxin like a derivative. What's interesting about this is his most famous paintings, 6 of them were about his physician. And his physician was giving him foxglove for dropsy. So, and there's also side effects with depression. There's some evidence that it may work with depression. So they were trying to help his depression. I mean, he chops off an ear over a girl. He's got dropsy, he's got medical conditions, so he's on foxglove. And if you get too much digoxin, before you go into blindness, you get a thing called chromatosis. It gets this brilliant use. Then you go into loss of color vision. Okay? Then you go black and white vision. Then you go into amaurosis fugax. Okay? Have y'all seen that in preeclampsia? Yeah? So when they recover, what comes back first? Black and white vision or color vision? You remember the cones and rods? Right? So cones are what? Color. Thank God that God made it that way, because color and cones I could remember. Okay, so rods are black and white. When Lewis and I were kids, and a few others, we had TVs like this, as big as this podium, 3 channels, and guess what? You had to get off the couch to change the channel, all 3 channels, and you sit back down. The volume's not right. You had to get back up and turn that. Okay, huge TVs. Now you've got what? Sophisticated TVs, plasma, 65-inch, multi-disc, HD, all this stuff, right? So very sophisticated. Cones are like the current TVs. Rods are like the black and whites, very primitive. So when you recover, they don't have a lot of sodium potassium pumps. So you recover black and white vision first, which is very similar to animals. That's what they have. Ultimately, color vision comes back. Cones have a lot of sodium potassium pumps. So if you're inhibiting them, it's going to take longer for those to recover and reset. Okay? So this pumps thing makes a lot of sense physiologically. Okay? Baha killed this. Then there was this brilliant investigator at the Medical College of Virginia, Scott Walsh and Yuping Wang, who were doing thromboxane prostacyclin. In the NIH, you chase the dollar. Okay? So they started funding that. Everybody goes that way, and everybody starts giving baby aspirin, etc. This dies. And nobody knew that it even died. I mean, this was at a funeral, nobody even showed up. So 1993 to 1996. From 1990 to 94, I was a resident at the University of Florida in Jacksonville, because I thought I was going to be a beach gynecologist. I thought that was going to be the greatest job in the world. Hang at the beach, have fun. Then I decided I want to be an MFM. One of my mentors said, well, you have to be known for something. Okay? You can't just be an MFM. You got to do research. Or somebody says something, they say, oh, you got to call that person. They're the expert. So at a party at his house, like a good attending, gave me a good dinner, some good wine. He lays this thing out on me. He says, you got to find something. So gives me a bottle of wine, and I'm walking from Atlantic Beach back to Ponte Vedra, about a 2-mile hike. And the night before, I had read a book, Wibbs, 1993, 19th edition, page 777. We talked about wobbling-like factors, EDLFs. I was like, that's interesting. I think maybe I could do that. So I came up with the idea. I then searched out that Wake Forest, Bowman Gray, had a guy who was kind of the world's expert. Thus, I went there. So that's the book. Unfortunately, at the end of my fellowship in 1996, the 20th edition comes out. So I know it's hard for you all to imagine this. Okay? We didn't have PubMed. We didn't have the internet. Okay? So that data I told you that killed it was in 87. In order to get all that stuff up, it takes about 10 years to make it into a book. So in this edition, 1996, all that I talked about was taken out of the book, because we don't talk about it anymore. It doesn't exist. It didn't work. And I was like, gosh, something's not right here. I'm doing all this work. I called New England Nuclear, and I asked them, did they change the antibody? They said, yeah, man. Everybody was calling and bitching. I mean, like cross-reactivity, it's this. These people aren't even on DIG. It's positive. You're creating problems for you. So they made it very specific. So indirectly, they killed the whole field by making it specific. So we had to figure another way around to measure these things. And that's what I spent my fellowship doing. So EDLS in general rise in normal pregnancy, normal menses, higher in multiples, and they disappear about 2 to 5 days in a normal postpartum mom. Okay? And the newborn, it's a different story. They're about 4 to 10 times higher. They last longer, 2 to 6 weeks, and they parallel catecholamine release. A stressful delivery, vaginal delivery, much higher levels, versus an easy C-section, lower levels. We know for sure it comes from the placenta, at least one aspect of it, and that's called merinobuphinogen. There's no arterial venous difference, so that suggests then that the placenta is the source, okay? So it's kind of equilibrium. There's a pathway potentially in the fetal adrenal gland. So if you have a baby that's in shock, what does the baby do? Perfuses the brain, the heart, and the adrenal gland, right? You or I, we have a hemorrhagic shock from gunshot, bus wreck, whatever. We preserve the brain, the heart, and the lungs. Adrenal gland is not as important in an ex utero human being. So the fetus uses the adrenal gland to control labor, stress response, etc. So it makes sense for this pathway to be in the adrenal glands. Gestational age has a negative correlation. So the earlier that a baby is born, the higher the level. The older a baby is, the lower the level. And then there's a direct and linear correlation in conditions such as cardiac, RDS, neck, IVH, jaundice, and pneumonia. So if a baby is born early with those diseases, significant increase in their levels, which then causes sodium potassium pump inhibition. And IUFDs, it's been found in small bowel, adrenal glands, in the highest amounts. And then correspondingly all tissues, but then gallbladder and liver would be the other two. Now this is an interesting phenomenon. There were some children who were institutionalized and on digoxin. They had an abrupt death, several of them. They started doing autopsies. Somebody did a dig level, and they were exceedingly high. The caregiver was then charged with intentional murder and overdosing of these neonates and infants. So what they found out was that that's not exactly true. The person didn't intentionally do it. They were shifting from the tissue to the serum, and they were using these crude antibodies, and their levels were high. So it was a false accusation. Thank goodness for who that was. So there's several candidates. There's at least 5 spikes that come off on HPLC. We've identified 3 of them. Marina-bifenogene, this is a group out of Baltimore at National Institutes of Aging. There's endogenous wabang out of Baltimore at Johns Hopkins. The group at Harvard that I got to work with when I was at Wake Forest has a pituitary extract that is very similar to wabang. So it looks like the pituitary may have a pathway in it as well. All of these correlate with its expression. If it's a high level, there's a significant inhibition of the sodium pump. So it's a direct effect. Now, what do we have in preeclampsia on the bench? Okay? We have placental levels that are exceedingly high, okay, in moms with preeclampsia. We have several membrane assays that you can use, and there's over 12 to 20 papers that have correlated pump inhibition with serum levels. There's antibodies raised to endogenous wabang and marina-bifenogene that show if you give that in animal models, in vitro, that you can reverse these pumps and reverse the inhibition. We've done that as well in over 8 papers. The first person to do it in vivo was our team that we did at Brigham Young University, where we took patients and actually were able to reverse it in vivo as well as in vitro and show a cause and effect with a pharmaceutical in preeclampsia. That's the first time anybody's ever done that with a pharmaceutical in preeclampsia. Work done right here at LSU. Yu Ping and Dave Lewis. Basically, when you give Digibind, it attenuates the expression of tumor necrosis factor alpha, which makes sense in that endothelial inflammatory thing because you're affecting membrane fluidity and cellular responses. So DIF does that. There's a boatload of papers on vascular resistance looking at animals, as well as ring studies, et cetera, where you can induce a contraction and reverse it with these fragmented antibodies. And then this paper, Yu Ping and Young did here, where they did Digifab, which is a biologic equivalent to Digibind, and were able to protect endothelial cells, preserve the polarity and their gaps, so that there was no leaking of a dye down into a dye paper. If you didn't do that and you incubated it with preeclamptic serum, the cells lost polarity and then they started having leaking, so suggesting cellular disruption. So Young and Yu Ping and Dave, you guys are contributing to all this good stuff. So clinical evidence. First one was in 1988, New England Journal of Medicine. Interesting paper. Bob Goodland. This guy is like the king of case reports, okay? He probably has a CV of 400 articles, and every one of them's a case report or a theory. Okay? On the Y prime, he's got blood pressure, mean heart pressure, and on Y secundum, he has urinary output. On the X, he plots out hours, and this is a lady with eclampsia, and he treats her for the first time with Digibind, okay, which is the original fragmented antibody. What's interesting about his paper, he's observed something I've never seen exactly this way. You can see he gives 10 milligrams IV push, and there's an immediate drop in the mean heart pressure. We've never observed that. It's usually about 6 hours before you start seeing an effect. Now, correspondingly, he gets an increase in urinary output. He repeats it again, same thing. You get this precipitous drop in blood pressure and an increase in urinary output. So suggesting then, when you have a vessel that's nice and tight, those pumps are inhibited, you reverse it, the vessels open up, blood pressure drops. Okay? The renal artery's got a spasm, so it opens up, and you start peeing more. Okay? So it makes sense clinically. Timing-wise, I'm not so sure about this, but that's in the New England Journal, and I'm not really jealous. It's okay. I'm cool not being in the New England Journal. All this data led me then to Wake Forest. We had a set of di twins, about 20 weeks, severe preeclampsia. David knows my former chairman. His name was Eberhard Müller-Heuback, and he was German, and he spit a lot when he talked, because the mouth is doing back and forth. And he told this lady she needed to terminate the pregnancy. He left town, and Mac Ernest took over, and she said, "Is there anything you can do?" Now, growing up in West Virginia, I wanted to get off the farm. Wake Forest promptly put me into a choice. I could either do the baboons or I could do sheep. There seemed to be a lot more research going on with the sheep, so I'm over there doing ultrasound on the sheep. I get a phone call, "Can you come see this person?" And I'm like, "Yeah, I got to get the manure and stuff off. I'll be right there." So I come and see her. I tell her I have an idea that we could potentially give her this drug. Maybe we could help her. I don't know. And before he did it, I called my Episcopal priest, who was on vacation. So we had a fill-in priest. He gives me a prayer, and we go give this drug. What we observed was this, okay? Her pressure's a labile. This is the Digitalis infusion. We didn't do a bolus like Goodwin, but we noticed a decrease in mean arc pressure. Okay? These are the numbers. Her dig level, using a crude antibody that we still had available at the time, was 0.4, which is high, okay? Meaning she's not on digoxin, okay? So that's a hit. During the infusion, we didn't do anything because Digifab, Digibind can interfere with the assay. Okay? But after the infusion, it was undetectable. Her blood pressure decreased. Diastolic really didn't change a whole lot, okay? But systolic, we noticed a big difference. Look at urinary output, almost doubling during the infusion. Okay? You stop the drug, she drops off. Creatinine clearance, okay? This suggests that she is what? She's not doing very well. She's a preeclamptic, right? Most preeclamptics don't pee real well, right? That's why we look. That's why Dr. Lewis is a fanatic at looking at that Foley, right? Where there's gold, there's urine, okay? And that tells you how well you're perfusing. So we double that. On the urine output, we increase creatinine clearance almost back to normal. Correspondingly, we doubled proteinuria. Okay? You stop it, proteinuria drops off, so does creatinine clearance and her urinary output. Dr. Eberhard Müller-Heuback comes back. Typical German fashion, was very upset. Again, I get, imagine this. I mean, David will tell you, my ass is chewed out. We need to terminate pregnancy, and then thus she's terminated. But we published that. Using that, I went to GlaxoSmithKline, who owned Digibind, and I went to the FDA, and I said, I want to do a study in pregnant women with this drug. I think we can do some good things for moms and babies potentially. So the FDA promptly picked me up, threw me out, and said, go do this in postpartum first, then we'll do antepartum. So we did a postpartum study. And we did 26 patients, 13 in each arm. Found a significant reduction in antihypertensive use. Okay, this is immediate postpartum after delivery, and no adverse events. And then this is just basically the graph showing in Digibind versus placebo, a lowering of the blood pressure faster and less hypertensives in that population. Okay? Now, this is the table of the lab values. There's two things you need to look at. The post-glucose, which is here, that's significantly lower in the Digibind group, and the magnesium is significantly lower. Is there any significance to that? Anybody think of any? These pumps are, what do we say, energy dependent? What's the energy source in the body? Glucose. If you're pushing the gas pedal, what happens to the gas tank? It goes down. If you're consuming on an energy basis glucose, what's going to happen? It's going to go down. Magnesium is almost 99.9% exclusively excreted how? Through the kidneys. If you make the kidneys work better, what happens? You pee. You pee out the MAD. Your MAD goes down, which is what we were seeing here. Okay. So we also looked, this is at Harvard, where we took those red cells, we took non-menstruating female volunteers, non-pregnant, in the first 2 weeks of cycle. About the third week, normal menstruation, you start getting red cell inhibition of the pumps, okay? And it makes sense from an endometrial standpoint. And then at the peak, right before you start the menses, that pumps are inhibited, the cells die, you then have menstruation. And it starts all over again. So we chose them as a normal control, normotensive, gestational age-matched controls, and then severe preeclamptics from our study. And what we were able to find was that pump inhibition, okay? So this is expressed as activity. So the more is better, less is bad, okay? So rubidium is a surrogate for potassium. It's a radiostable isotope. So if a cell takes it up, it lights up. If it doesn't take it up, there's a way that then you can calculate on how much the activity is. And what we see is that in normal pregnancy, you had a significant increase in pump activity. Non-pregnant controls, you had about 61. But look at the severe preeclamptics. Okay? It was about half of what normal pregnancy was. Okay? And about 25% of what a non-menstruating female would be. Okay, so I took all this and moved to LSU. Okay? This is my faculty picture. And so I know the Duck Dynasty people over there. This is in the early 90s, man. They copied all this. Okay, so, but I enjoyed my time here. And that's my daughter, Darby, who now has given me a 3-year-old granddaughter who looks just like her. So we had fun. There's the ping. The ping made my life great here. And then David, he brought me out of the closet. I became comfortable with myself, and the rest is history. I love that guy. David will tell you a good story. We had a patient here. This little girl now is 22 years old now. She weighed 408 grams, and when I delivered her, she fit in my hand. I had brought drug from Wake Forest. I had some left over. True story. I am the world's expert on this drug, so I knew how to transport it safely. I had a special refrigerator at my house, had beer and the drug in it. This lady comes in, severe preeclampsia. Okay? Very small baby, doesn't look good. I talked to her, and she says, yes, let's do it. So, word to the wise, don't get bright ideas, okay? So, do as I say, not as I do, okay? I went home, moved the beer, got the drug, came back, and for about the next 2 or 3 days, I gave her the drug. I mixed it, gave it to her, etc. Okay? Ultimately, somebody ratted me out, and then we had to deliver her. But she's 22 years old now, no IVH, no ROP, nothing, no long-term things. Graduated college, and she likes to fish, and she catches big fish. Dr. Clay, who was one of the deans at the time, obviously was impressed with my talent and potential, because David calls me and says, the dean wants to see us. Finally, somebody's recognizing me here. Okay. Dr. Clay could make a sailor blush, and I'm a Southern boy. I know cuss words. He had cuss words that I've never heard of. I said, sir, do you mind if I write that down and trademark that? Because that's a good one. I got to remember that one. So for 30 minutes, it was the death march when I went over there. He's screaming and all this. And he says, okay, now don't be going home and getting drugs out of your refrigerator and bring them in here and give them patients. Okay, so that's rule 1. Okay? Rule 2, you got to get an IRB for these kind of things. Rule 3, I got some daughters. They get preeclampsia. You're the son of a bitch that's going to be taken care of. Yes, sir. Okay. So I go back, and David's like, well, you fired? I'm like, no. He said I'm going to take care of his daughters. I didn't tell him the other part, but I suspect Dr. Clay filled you in on the other things later. Okay? So UP comes to town. We do all this basic stuff. I love it here. Okay, really, they got great preeclamptics. I mean, it is a heyday. Okay. Unfortunately, we didn't have a very good chair at the time. We had David as our division chief, and so Tennessee gave me a chance to come home, so I went back, and we've continued things. So more good things from Shreveport. Okay, Dr. Brewery here was with us for 3 years in Chattanooga, and we took an eclamptic and gave her repeated dosing, and we nursed her out, got steroids, etc. This baby, and all babies that we've given DIF to, none of them have grade 3 or 4 IVH, okay, or NEC. So that's what's really cool about this. We're seeing neonatal effects. So we were able to do some good things with that lady. We've done about 15 of those such ladies off-label. We've done a bunch of stuff with pumps, looking at how you manipulate them, reverse them, etc. If you really are that excited about it, call me and we'll go deep, okay? We can go deep on this dissertation. If not, then I'll just suffice it and trust me on that one. And there are references that you can say, check me and see if I'm bullshitting or not, okay? So GlaxoSmithKline, after the third time, flies to town. And this guy here is pretty famous. He's in The Tipping Point. Malcolm Gladwell, y'all, any of those you've read? I know you're reading cellular physiology, things like that. You're not doing outside reading, right? Please outside read. You need to be well-rounded. So this is Andy Johnston. He's the father of Wellbutrin and Zyban. So they attach him to me to keep me on task and doing what we're supposed to be doing. And we start a project. We did a thing called the Deep Studies. Multicenter, I think we had 15 sites or so. We ended up with 51 patients, 23 and 5/7 to 33 and 5/7, or 11 institutions. We had 15 who had consented, 11 who enrolled. LSU Shreveport was one of them. We administered Digifab, or Digibind at that time, every 6 hours until delivery or 48 hours were completed. And they got standard of care, and they were matched to a placebo. So we found no effect on blood pressure, no adverse effects, that's good. ATPase at baseline was no different than the placebo, so suggesting the pumps were inhibited. However, after 24 hours of diff, the sodium potassium pump activity increased significantly in the diff-treated group versus the placebo group. There were 2 neonatal deaths. Both of them were in the placebo group. So this is the overall trial outcome on the neonates, okay? So really nothing exciting here because there's nothing significant, right? What's really interesting about this is when we looked at the pump data, okay, because we planned a secondary analysis, about 80% of women who have early onset severe preeclampsia are positive for this factor. 1/5 were negative for the factor. If you don't have the factor, this shouldn't work. Okay? So that's why we wanted to throw out the women who were negative and really concentrate on women who had placebo and diff who were EDLF positive. In other words, it doesn't do you any good to give a chemotherapeutic drug to somebody who doesn't have cancer. Okay? So we concentrated that. So this was a planned secondary analysis. This is in the Gray Journal. Okay? 80% were positive, 19 and 17 respectively. Here's what we found. This is a total flip-flop. The women who were positive, okay, it was opposite in the total control. In the total study, the diff-treated patients didn't go as long. But if they were positive for the factor, there's a trend towards a longer latency. Okay? Latency being a surrogate potentially for better neonatal outcome. Okay? Fetal heart rate abnormalities. Again, total reversal. There was a trend again. Fetal heart rate abnormalities do what? What did we say earlier? You have stress, you do catecholamines, pump inhibition goes up. If you're able to reverse that, those babies do better. We've seen this with Dopplers. We've seen it on the traces. IVH. No baby in the diff-treated group had an IVH. Now we had 2 with grade 1 or 2 in the total, but they were negative for the factor. So in this group, nobody had the factor, had IVH, which has been true in all the other patients we've had. Infants, less than 1250, no difference. Pumps do what in terms of amino acids? They help bring amino acids over to the fetus. The fetus preferentially grows by amino acids. If you inhibit that, you're going to have a higher incidence of growth restriction, which is what David and I were talking about a little bit earlier. Neonatal death. One of them, of the 2 in the placebo group, was positive. Had a massive bleed in the head, grade 4. That's what kills these kids, or then long-term implications, neurological handicaps, etc. On the maternal side, okay, 1 patient with pulmonary edema, 6 pulmonary edema in the placebo group. Okay? We had a couple of other trends. This is exactly the opposite of the total patient. When we concentrated, there was a suggestion, what we had observed ultimately in that postpartum trial and others, a decrease in the blood pressure. So we think that may be true. This may be a type 2 error, okay? Not enough patients. If you look at the duration and how we give this, okay? So this is pump activity, okay? So if it's low, like here, this is before we treat anything. If you're low, that means that pump is inhibited, it's not moving. Okay? So there's a lot of factors, what that says. When we started giving diff, about 12 hours in, you see there's about a 10% increase in pump activity. meaning you're lowering this endogenous factor. And then 24 and 48 hours, you can see you've about 15 to maybe as high as 18% recovery. So you're reversing the pump. Okay? When you stop the drug infusion, you start to see it fall off. Okay? So suggesting a pharmacological effect on a pathophysiological expression of preeclampsia. This study is the first and only to ever do anything like that. So it's very cool what we've been able to do with this. Okay? So what this slide picks out is this. If you look at, if you don't have any EDLF, you really don't have that much reduction in your creatinine clearance. Okay? If you have a low expression of EDLF, there's more inhibition than negative, but not that impressive. The people who had very high EDLS, or pump inhibition, had significant creatinine clearance, 40+%, okay? Reduction in creatinine clearance. When you give a drug, the Digitalis, you have basically reduction back towards the norm in your creatinine clearance. If they got placebo, which if you got somebody up there right now on MAG, this is what their creatinine clearance is going to look like, because you're not giving anything to start reversing it. What's one of the long-term problems with people who have severe preeclampsia long-term? They have increased cardiovascular, stroke, okay, death, acute renal failure, chronic renal failure. So there's something going on there a lot more than meets the eye. And so we think that there may be some positive effects even on down the road for these women. So what we're going to do now is we're prospectively going to have another deep trial. This time, though, bigger numbers, 200 patients. We currently have, I think, 15 sites consented, 11 sites that are enrolling. Okay? We're looking for 30 to 40 sites, high-quality sites like here. You guys have just enrolled a patient. I think Donna and Dave was telling me last night, within the last week. The team's coming down next week. If you get another one, do it. Dr. Breyer's got patients. If you can help us, we appreciate that. It's basically ACOG criteria, not complicated. We have a gestational age range, 23 and 5 to, Donna, what is it, 32? Is it 32? 31 and 5 or something like that? I can't remember off the top of my head right now. For the enrollment, for this one, yeah.
31.6.
31.6, yeah. Because remember the first slide, we talked about money? If we're going to make a difference, we got to take care of those early babies. I'm really not concerned about a 36-week baby. They're going to do fine, okay? I don't mean that bad, okay? I do care, okay? Just in the purpose of the study, we want to do something that's good, right? No genetic chromosomal things, P-prom. No reason for delivery right now. Standard of care. I'm not asking you to do anything different. The only thing different is you're going to give a fake placebo of saline, or you're going to get Digitalis, okay? 1 to 2. We're going to look at maternal and neonatal outcomes and then compare a diff versus placebo. So really a straightforward trial. So I'm here today to tell you what can I do to help you, okay? Siri and I have this love-hate relationship, okay? I swear I think she's out to get me. I sent a text the other day and I said, bring your things and let's go to the meeting room and have a meeting. So everybody shows up. I said, well, where's your thongs? I said, what are you talking about? They said, well, did you read your text? And I'm like, no. They said, well, you said bring your thongs. So I was like, I said, oh, okay. So I had to do this 3 or 4 times just to get this right, because she really does. She hates me. So I'm here to help you get this thing going and help us find out, because if these observations that we've seen in prior trials are repeated and confirmed, we're sitting on something that moms and babies can benefit from. And I can tell you, I've been at this a long time. I mean, that's why you saw I had hair, and it was black. Okay, 3 kids and a granddaughter, plus countless numbers of students and residents. It's made me bald, fat, and gray, okay? So I still love y'all. I mean, I wouldn't give up medical education for the world, but we need to do better for women and babies. No one's done anything. We need to do something. And I think if this pans out, then we could be doing something. So we need you to help. Okay? So my motto, I've learned a lot, okay? If it doesn't make me a better person, happy, or help someone, then I ain't doing it. Okay? I think this is something that we could all say would make me a better person, meaning me and you, help somebody, and certainly should make us happy. So I think you can get into this, okay? I'd like to thank Dr. Buckaloo, Barman M. Buckaloo, former dean, chairman, division chief, nephrologist emeritus. This guy's world famous. The M is more, but for me it means mentor, and he really helped me and I still see him on a regular basis. Nancy and Lori, who keep me straight down in Chattanooga. Lori does all of our research. Nancy's my admin. She's my Shannon. This is Allison and Nona. They started this with me at Wake Forest. And then I can't forget Homie, okay? So David F. Lewis, okay? I know you all probably y'all still know the LGDL? Lord God Dave Lewis? You don't know that one? Okay, yeah, okay. You can call him that, okay? He's the grand poobah. But to me, that's friend. Okay? That's what the F is for. And he's one of the best advocates for residents and students. And I promise you, you will learn. Okay? And you will be an excellent practitioner if you listen to what that guy says. My last thing I tell you is this. Happiness is not a destination. Okay? It's really a way of life. I really enjoy coming here because I get to see all my friends, eat Strong's, Superiors, okay, Herbie K's, and it makes life fun. It's not about that destination. Okay? And I know you're young and impressionable, and you're thinking, okay, I got 2 more years, I got 1 more year. Enjoy the ride. It goes by fast. I wake up in the morning sometimes, and I remember vividly the Louisiana 150% humidity. I've never seen that before, and it seems like yesterday. And it passes fast. So enjoy the ride, enjoy everything, every moment. Live it to its fullest, okay? So with that, I'll conclude and give you any opportunity to ask anything that you want to know about this, and I'm happy to share stuff. I'm going to send an article to Claude. It's in peer review right now. I'm going to ask internally if you just will keep it here. Dr. Buckaloo wrote it. I helped him write it. It really does a good job. He is the guy who invented a lot of this stuff. And so it's a great chronology of 50s and 60s, not music, but all the way through. And if you'll just keep it amongst yourselves, it really would give you even a bigger depth. It's a great review of this whole area. Okay, so I'll send that to you, Claude, if you'll disseminate it amongst the troops here. So any questions?
Dave, is there a midpoint analysis plan in the study?
Yeah, we've got a safety committee. Dave knows him real well too. Jimmy Van Hook is our safety chair. And so he and 2 appointed physicians, I don't know who they are, they will get the data as Group A and Group B at 100 patients. If one group is just astronomically different, then, there's some parameters where they'll unblind. If there's significance, but it's like 0.5 or something like that, then we'll keep going. Okay? Obviously, if there's any adverse things, then we would terminate. But right now, last night, Donna asked me where we are. We've got 16 patients enrolled. Okay? We've got 5 this month. Okay? So it's starting to pick up because we're getting more sites. We need more sites. Okay? We need more patients. And I just think at the end of the day, remember your Hippocratic Oath, we all got in this because we care about people. We're all doing this, and we're making a living because of someone else's malady. And so keep that in perspective, and with this research, if we can get these women in and get them taken care of. On the first study we did, I couldn't honestly tell you if there's a benefit, because we thought there was, we had some anecdotal data. We've got 2A data, which is pretty good for pharmaceuticals. 2A data that says babies do better, okay? Moms do better. So that should help enrollment. For institution and Caddo Parish and the numbers you all have here, you guys ought to be able to do at least 1 a month. UPing has churned and burned preeclampsia research for years, so I know they're here. So if we can get them, that would really help us a lot. But so we're going to try to do 30 to 40 sites. We're looking at Puerto Rico, but unfortunately with the hurricane, they don't have any power. You can't do research without power. Another headwind has been IV bags. Are y'all having any problems? We're out of drugs. Our epidurals, and we're having to do epidurals for C-sections, on elective C-sections, because we don't have stuff to do spinals. The IV bags, there's 4 companies who make them. 3 of them, they're all in Puerto Rico. One that didn't get hurt had a FDA-ordered shutdown to clean. It's a preventative thing. And they were getting ready to shut it down. The FDA superseded and said, no, don't shut it down. So that one's going. The other three, they're trying to get it back up. I mean, we're running out of IV bags. So that's been a little bit of a headwind. But we're looking for sites. Those of you who know some other places might be interested, we're happy to enroll. So, Claude? And remember, no Henderson Hasselbeck. Okay, the pharmacists over here are going to bust me here.
One is, how do you come up with 4 days? And number 2, how long is this effect?
So, good question. Okay, and I wish I could give you the Henderson Hasselbeck and all that stuff. Okay? The truth of the matter is this. This drug, it takes about a year. It's a biologic. Okay? It takes about a year to raise. They inject sheep in New Zealand, and they raise the antibodies, okay, stimulate them, do a bloodletting, purify the antibody. It's a whole antibody. Goes across the pond somewhere in Italy. They cleave off the FC portion of the antibody. Gets cleaned up, and all that stuff, lyophilized, goes to Baltimore, Maryland, put into the little bottle. So it's very expensive. About $150 or so to make it is what I've been told. I don't know. Right now, because there's a decrease in digoxin use, therefore, corresponding there's a decrease in digitoxicity, it becomes more expensive for them to make it. Now, not the actual thing, but because of the markets and all that. So it's an expensive drug. When we got this, quite easy the math, we had a $10 million grant. So we had enough money to run the study, pay all the sites, and buy this much drug. Okay? That's why there's an exclusion. Now, if you get somebody in there that's really, really big, a 500-kilo woman, call me, because it's weight-based, and they suck up. One woman could suck up, a big supply. So it really is a cost and availability issue. The original deep study, we did 2 days. FDA asked us to go up to 4 days, because and we're doing a little bit different dosing. But there's not a great scientific answer. It's really an economics and FDA request. So I can tell you're a pharmacist. Pharmacists always ask that question. Doctors were like, okay, we'll do 1 day, 4 day, whatever you want. Okay. Any other questions?
Just another advantage about this study is it's not one that you have to start the minute that you make a diagnosis. And a lot of times you have that in these type of studies. You have a small window. Remember that first study, that was a big problem. We were starting people at 2 a.m. and attending had to see them every 6 hours or something. It was just a lot of work. This one is not a lot of work. This lady had been in the hospital for a couple of days, I think, all the time in New Orleans at some meetings, and came back in. And I took one look at her and said, I think I asked somebody if it's a growth restriction. They said no. I said, this lady is on my criteria. And I need you to give me the percentage of growth restriction that we can put in this. I think one of the problems we have here with we have so many people that have abnormal Dopplers, and that is an exclusion, as I recall, for this. But the data's telling me it's 5%.
Less than 50%.
Less than a 50% drop.
And if you understand the pathophysiology, if you really got a high expression of EDLF, you're going to inhibit the placental pumps,
Right.
but you carry the amino acids. And I can tell you that, having been here, your preeclamptics, this I-10 to I-20 belt, okay? Chattanooga is the #1 stroke center in the U.S. Okay, we have more strokes, and I mean that's not me saying it. I mean there's data for that. These women end up having strokes. I think some of this is some genotype. Of course, I did have a biscuit and gravy this morning at Strawn, so some of our cultural embracing of food. Okay, a lot of these things go into determining that. Preeclampsia, in my opinion, really is, if you have a gestational diabetic, what do you tell them? 10 years is a 50% chance you'll be a diabetic, 15 years, 75%. It's like a crystal ball. Preeclampsia is a crystal ball. It is a window to your future health. And these are women that, they're not normal, okay? Even though they deliver and we think, they're good, there we go. I really think as obstetricians, we need to protect these women. Yearly thyroid, cholesterols, making sure they're not hypertensive, weight control. All those things are very important. And I think you need to be doing your numbers, making sure that their creatinine clearance and stuff stays where it is, okay? So there's a lot of things long-term we can do. And I think they ought to be on a baby aspirin because they tend to get pregnant again. And baby aspirin doesn't hurt anybody, and baby aspirin helps long-term. So public health measure. That's pretty cheap. Folic acid and baby aspirin.
Is baby aspirin, is that not a contraindication?
No, ma'am. Now, if they've been on it and they've been at risk, they were on it, that's fine. So we welcome them. Basically, it's just once you make the diagnosis, that's it. Well, thank you all. Thank you all so much.